Good evening, everyone. We'll just wait for 2 minutes to let everybody join in and then we'll start, okay? Hi, everyone. Good evening and welcome to this session. And we are going to be looking at the important topics for INI-CET November 2024. All right. So, starting with the radiology. Okay, so I have just extracted these topics from pyqs. All right, so these topics are must read topics. Okay, you can't skip these topics. And the frequently asked pyqs was based on these topics. Okay, so please note it down this, and we are going to be discussing some topics from this. We can't actually discuss everything together, but what I feel is important that I'm going to discuss today. Okay, but for now you just note down these very important topics from radiology. They can ask you these radiographic views, okay, and their indication. So they can give you the submental vertex view. Okay, so you have to identify actually the submental vertex and what is the indication of it, or jug handle view, what is the indication of it. Okay, then you have to be thorough with the developmental disturbances. Okay, so there are two topics you have to be thorough with. First is developmental disturbances, second one is the syndrome based questions. Okay, you have to be thorough with all the syndromes, the genes affected in the syndrome, because in INI-CET exam they are the frequently asked questions. Okay, in developmental disturbances, radiographic, how it appears radiographically, that is also very important. So in that also, dens invaginatus, dens indente, talons cusp, concrescence, dilacerations, ghost teeth. Okay, in which condition you see ghost teeth, shell teeth, very important. Okay, next is normal anatomic landmarks, and there are two landmarks which were asked in PYQ. So first is nutrient canals. Okay, nutrient canals will be seen as a radiolucent line. Okay, radiolucent uniform bands. Okay, running below the incisors. Okay, most commonly below the incisors. They can also be seen below molars also, but most commonly incisors, right? And Y line of Annis. Okay, which structure superimposes to form this Y shape or Y line of Annis? That is very important. Okay, next, most important, SLOB rule. Many questions were asked based on SLOB rule. Okay, SLOB rule, buckle shift, buckle rule, or tube shift technique. Okay, it is also called as all of these. So one question based on SLOB, we are going to discuss SLOB rule. Radiographic faults. So while taking radiograph, what are technical faults or errors you are doing, what are processing errors you are doing, that gives us radiographic faults, right? So we these faults are also important, how it will appear on the radiograph. Okay, that is important. Maxillary sinusitis. In maxillary sinusitis, how is the radiographic appearance of this? Okay, how the sinusitis appears radiographically, and what is the indicated radiograph for seeing the maxillary sinus? That is also very important, right? Next is composition of developer and fixer. Okay, this there were questions based on this composition of developer and fixer. Be thorough with this. All right, next we have medicine. Okay, so from oral medicine, I've already told you syndromes associated questions. You have to be thorough with the features, you have to be thorough with the genes associated with these syndromes, right? Next is the clinical based questions. Most commonly asked clinical based questions are geographic tongue based on these conditions. Geographic tongue, candidiasis, pemphigus, pemphigoid. All right. So there can be image based questions. Good evening, everybody. Good evening. Image based questions. All right. They can ask you clinical based questions, so they can give you features. Okay. And how to diagnose these conditions, how to diagnose these conditions, or they can also ask you treatment advised in all of these conditions, right? Pemphigus and pemphigoid, you have to be thorough with how these two conditions appears in DIF, direct immunofluorescence, right? We have fishnet pattern, chicken wire pattern, right? So yeah. Next, OSMF based clinical question. Okay, they can give you features, reduced mouth opening, blanching, and everything. Okay, Epulis, we have a growth on gingiva. We have discussed different types of epulis, right? Next, we have cherubism. Cherubism based in last year, like this year only, May INI-CET asked one question based on cherubism. Okay, so cherubism very important. Pages disease, fibrous dysplasia. What is the radiographic appearance in both? Okay, fibrous dysplasia shows four radiographic appearances. You need to know that, right? Hyperparathyroidism, frequently asked question based on hyperparathyroidism. Odontome, this is also frequently asked questions. So, odontome, hyperparathyroidism, cherubism, all right, syndrome based questions. These are the topics that you must know. All right. Okay. Next, move on to the I am going to talk about the most frequently asked syndromes, okay, and how it appears radiographically. What are other features seen in these syndromes, okay? First syndrome that we are going to see is the Crouzon syndrome, okay? Crouzon syndrome. Crouzon syndrome is also called as craniofacial dysostosis. Craniofacial dysostosis, right? And this condition occurs due to why this condition occurs basically is due to early or premature closure of sutures, right? Premature closure of sutures. Okay, what is this termed as? This is termed as craniosynostosis. Craniosynostosis, right? Now, in this condition, as you can see in this radiograph also, we will see one feature known as brachycephaly. What is brachycephaly? The dimensions of the skull reduces. There is a flattening at the occlusal aspect, as you can appreciate in the radiograph also, and in the clinical picture of the patient also, right? The flattening of occlusal aspect is seen, that is called as brachycephaly. Okay, next feature is hypertelorism. Hypertelorism. Okay, next feature is proptosis. What is proptosis? Bulging eyes, bulging of eyes, right? Bulging of eyes. Then related to oral cavity, hypoplastic maxilla. Hypoplastic maxilla is seen, and due to hypoplastic maxilla, the crowding of teeth will be seen, right? And what happens due to premature closure of suture? What happens is there is an increased intracranial pressure. Increased intracranial pressure, and due to increased intracranial pressure, what happens is the shape of the skull becomes like this. Okay, the appearance of this radiograph or skull radiograph like this. Why this appearance happens is due to increased intracranial pressure. Okay, due to growing brain. Okay, there is a premature closure of suture, but the underlying growing brain, due to growing brain, there are markings, these radiolucencies, which you can see. These are radiolucency like depressions. These are called as digital impressions. These are called as digital impressions. Okay, digital impressions, and these digital impressions gives one appearance seen in Crouzon syndrome, which we call it as a copper beaten appearance, right? Copper beaten or beaten metal appearance. All right. So this is Crouzon syndrome. All right. Next syndrome that we have is hemifacial microsomia. So I am discussing the most frequently asked syndromes only, all right? Hemifacial microsomia, you can write down it as a second most common developmental craniofacial anomaly. Okay, after cleft lip and palate, this is second most common developmental uh, anomaly. Okay, hemifacial means half of the face is affected. Okay, hemifacial microsomia. So what happens exactly is the growth and the development of half of the face is reduced. Okay, growth and development of half of the face, so patient looks somewhat like this. And when you see the radiograph, what actually you see in the radiograph is, when you see this radiograph, the patient, the jaw is curved, or jaw curved towards the affected side, towards the affected side, right? Jaw is curved towards the affected side. Also, when you compare this right and left side, right side pe you don't see any condyle and coronoid process, right? Whereas on left side there is a normal condyle coronoid process. So what happens is the condyle coronoid process ramus, there is a lack of development of all of these parts. All right. So reduction in the size of bone of the affected side takes place, right? So radiographically, you see all of these features. And talking about dentition में what happens is number of teeth and size of teeth reduced. Both, okay? Both are reduced, right? Again, one important feature seen in hemifacial microsomia is this, the external ear. Okay, there is a aplasia or hypoplasia of external ear. This is important feature. Okay, aplasia or hypoplasia of external ear. All right, and this is termed as microtia. Please remember, this is termed as microtia. All right. So these are some features related to hemifacial microsomia. All right. Are we clear with this? Okay. Next important syndrome that we have and most frequently asked is this syndrome, which we call it as a Treacher Collins syndrome. This is most commonly asked syndrome, Treacher Collins syndrome. And Treacher Collins syndrome is also called as mandibulofacial dysostosis. Mandibulofacial dysostosis. The gene affected in this is TCOF1 gene. Okay. The mutation in this gene on chromosome 5, okay, is affected. Treacher Collins or mandibulofacial dysostosis. The main important feature in this is, as you can see, there is a underdeveloped, or you can say absence of zygomatic bone. This is 3D skull radiograph, 3D skull. You can see there is a absence of zygomatic bone. After orbit directly we have the maxillary bone. Okay, so absence of zygomatic bone is there. Sometimes there is a underdeveloped zygomatic bone. Underdeveloped. Okay. Now, due to absence of zygomatic bone, what happens is there is a downward inclination of palpebral fissure. Can you see here? There is a downward inclination of palpebral fissure. Okay. Talking about mandible, mandible is underdeveloped, okay, and there is a downward inclination of mandible, as you can see in the radiograph also, okay, downward inclination of mandible, and there is a, again, hypoplasia of external ear auditory canal is present, okay. So downward inclination of mandible, as you can see in this radiograph also, right? Hypoplasia of external ear and auditory canal, right? Now, when we talk about radiographic feature of this Treacher Collins, again, absence or hypoplasia of zygomatic bone is there. Steep mandibular angle is there, okay? Steep mandibular angle, okay? So I'll just write down the radiographic features over here, okay? Hypoplastic zygomatic bone, zygomatic bone, all right. Steep mandibular angle, steep mandibular angle, and ramus is short, ramus is short, okay. Now, there are one important feature that is seen in 18% cases of Treacher Collins syndrome, which is cervical spine is affected. Okay, cervical spine is affected, and what are the features? Spina bifida occulta. Spina bifida occulta is the failure of, you can say, development of neural tube. Okay, so spina bifida occulta. Then we have dysmorphic C1. Okay, dysmorphic C1 vertebra. The shape is different, and then the reduced space between C2 and C3 vertebra. So these are features affecting the cervical spine, okay, in Treacher Collins syndrome. So you can just remember these features, all right. You can see here the ramus is short, there is steep mandibular angle, right, absence of zygomatic bone. All right. Next syndrome that we have, after uh, seeing the image only, you can just identify this syndrome, right? You can answer in the chat box, all right? You can answer in the chat box. I can see the chat box. Okay. All right. So this syndrome is which syndrome? Cleidocranial dysplasia. This syndrome is cleidocranial dysplasia, right? And the mutation of which gene is there? Mutation of RUNX2 gene, okay, on chromosome 6. So mutation in RUNX2 gene on chromosome 6 is affected, right? And in cleidocranial dysplasia, again, what you can see is the hypoplastic clavicle, right? Hypoplastic or aplasia of clavicle bone, right? So due to hypoplasia or aplasia of clavicle bone, patient can move the shoulder girdle very easily, right? Next is brachycephalic brachycephalic skull. Brachycephalic skull, okay. Hypertelorism again present. Hypertelorism, all right. Next important thing is the open, or you can say, I'll just show you here. Okay, there is a Open metopic suture. Open metopic suture. Metopic suture is the suture which joins the frontal bone. Okay, so open metopic suture with light bulb shape, light bulb shaped skull. Okay, so they can ask you this question: in which condition you can see light bulb shaped skull? You can see this light bulb shaped skull. This condition is seen in cleidocranial dysplasia, okay, with open metopic sutures. All right, talking about dentition. Talking about dentition, what do we see is the prolonged retention of primary teeth. Prolonged retention of primary teeth, and of course, permanent, unerupted permanent teeth. Okay, unerupted permanent teeth or supernumerary teeth. Okay, so this light bulb shaped, very important. The gene, very important. All right, open metopic suture, very important feature. All right, next important syndrome that are often asked is Pierre Robin. Pierre Robin syndrome. Okay, Pierre Robin syndrome. You all know what are the features seen in Pierre Robin syndrome. Okay, so first is micrognathia. Micrognathia is the first syndrome, first feature. Micrognathia, small mouth, cleft palate. Cleft palate is seen, and glossoptosis. Glossoptosis. Micrognathia, small mouth, cleft palate, you know. Glossoptosis is the improper positioning of the tongue. Okay, what happens here is due to small mandible, okay, tongue has no space for movement. Okay, so tongue is improperly positioned, that can cause airway obstruction also. Okay, so in Pierre Robin, these are the features. All right. So these are about syndromes. Now I am going to show you some skull appearances seen in systemic conditions. So you can just answer in the chat box. Okay, fast. We can just revise these topics. Okay, first is this appearance. We call this as a salt and pepper appearance. So come on, answer. Salt and pepper appearances seen in which condition? Salt and pepper. Salt and pepper. Okay, salt and pepper appearance seen in hyperparathyroidism. Hyperparathyroidism, right? Hyperparathyroidism. This is salt and pepper appearance, the granular appearance. You will see it on the skull, right? Salt and pepper appearance is hyperparathyroidism. Next is this punched out. So the name of the appearance is punched out radiolucent lesions. All right, punched out radiolucent lesions seen in multiple myeloma. Multiple myeloma, right? Multiple myeloma. These are punched out. These well-defined radiolucent lesions, right? These are punched out radiolucent lesions, right? Okay. Next is this. This is what tram line calcifications. Tram line calcifications. Tram line calcifications is a feature of which syndrome? Is the feature of Sturge-Weber syndrome. Tram line calcifications. Right? Right. Okay. Tram line calcifications. Next we have, okay. Now I'm going to discuss about object localization. Object localization. Okay, now object localization is done with the two techniques. Okay, first technique is the right angle technique. Right angle technique. Okay, and the second technique is slob rule. Slob rule is also called as cube shift technique. It is also called as Vama rule. Buccal always moves away. Okay. It is also called as Clark's rule. Okay. So these are the two techniques that we are going to discuss about object localization. Now, what is object localization? When you take, say, one, first you take IOPA, okay, first you take IOPA, okay, and you notice there is a supernumerary tooth or impacted tooth there. All right, now you want to locate whether this impacted tooth or supernumerary tooth is located buccally or lingually. The second radiograph you take is the occlusal radiograph. Occlusal radiograph, right? Now here you can easily tell that this tooth is located lingually, right? This tooth is located lingually, right? This is called as right angle technique, okay? Just take a two radiographs and you will know the location. All right. Now next technique is the slob rule. Slob rule also very easy. Okay. First you take IOPA with normal angulations, right? First IOPA, you notice some foreign material. Say foreign material here is this radio opaque small mass, right? Now second radiograph you take by shifting your X-ray tube to mesial side, right? When you take this second IOPA by shifting the tube mesially, mesial tube shift, right? Now check whether this object, this foreign radio opaque mass, is shifting mesially or distally. All right. So here in second radiograph, as you can see, in first radiograph, the material radio opaque mass was below the apex of second premolar. Now here this object is shifted mesially, right? So if your object is shifting to same side of the tube shift, okay, that means your object is located lingually. Your object is located lingually. All right. If your object is moved, would have moved to distal side, that means opposite side to the tube shift, that means your object is located buccally. Okay, this is the simple rule. Just remember, if your object is moving same side to the tube shift, it is located lingually. Okay, and opposite for buccal. All right, I hope this is clear. SLOB rule, I hope this is a clear. Okay, so this you take or you apply. Are many questions based on slob rule. They can give you roots of premolar and everything. Just apply this simple statement. If your object is lingually, that means your tube has moved mesial side, okay, or the same side. All right. I hope this is clear. Okay. Next we have uh, radiographs, different radiographs for different indications. Okay, different radiographs for different indications. First radiograph that we take for paranasal sinuses. For paranasal sinuses, you take Granger or Caldwell projection. We call it as a PA view, posterior anterior view, right? So Granger view was the old view. Now the Granger has been modified into modified PA, which is also called Caldwell view. So for paranasal sinuses, you take Caldwell projection. Okay, Caldwell projection. Then next is for Leaford fracture 1, 2, 3. Leaford fracture 1, 2, 3. Then a fracture of nasoethmoidal bone, orbital fracture, coronoid fracture. Okay, for these you take standard occipitomental view, standard occipitomental, and then we have modified occipitomental, 30-degree modified occipitomental. So you can choose anything between these two. Okay, but if in option you have both of this view, you can go for 30-degree occipitomental view. Okay, next is the maxillary sinus. For seeing the maxillary sinus specifically, you have the PA Waters view. PA Waters view. Okay, PA Waters for maxillary sinus. Then we have for fracture of body and ramus of mandible, we have Lateral oblique view, okay, for fracture of body and ramus, right? Next we have SMV, which is submental vertex, to check the base of the skull, anything related to base of the skull, or you can also check the expansile lesion in the palate, okay. You take SMV view, okay. Next is a fracture of zygomatic arch. I am going to show you different radiographs also, how it actually looks. Okay. Fracture of zygomatic arch ke liye you take jug handle view. Okay. Next we have is the fracture of condylar neck. Condylar neck fracture is seen with the help of reverse Towns view. Okay, reverse Towns view. Next, we have TMJ ke liye different views. So, seeing the medial aspect of the TMJ, you have transpharyngeal view. To check lateral aspect of the condyle, you have transcranial view. For medial or lateral displacement of the fractured segment, you take transorbital, which is from the front. Okay, transorbital view. To check bony ankylosis, right? Bony ankylosis, we take CT or CBCT. To check the anything related with the disc, okay? Disc is soft tissue, so you take MRI. All right. So these are different radiographs and the best view to best or radiograph to check these structures. Okay. Next, yeah. So identifying radiograph is also very important. They might give you one radiograph, identify this radiograph or indications for this radiograph. Okay. So this is a PA Waters view. PA Waters view, we all know, is done to check maxillary sinus, right? So you can see this sinus, both sinus. You can see nasal septum also clearly. You can see the orbits, you can see frontal sinuses also. Okay, so PA Waters, the view looks like this, and the indications is for checking maxillary sinus. All right. Next we have is this. This view is SMV, which is submento vertex. Submento vertex view. Okay, submento vertex is done to check the base of the skull, right? Base of the skull check करने के लिए we take SMV. Okay, SMV में can you see this complete base of the skull is appreciated, and the expansile lesion in the palatal region is also seen. So you can check expansile lesions in the palatal region, right? Now coming on to the next view, which is jug handle. Jug handle view. अब jug handle में you can see this view, and you indicate or indications for this view is fracture of zygomatic arch. Fracture of zygomatic arch, right? Why this is called as jug handle? Because it looks like a handles of jug, right? Here, so these are zygomatic arches. So fracture of zygomatic arches are clearly seen in this. All right. Coming on to the next view, this is reverse Towns. Reverse Towns view. Now reverse Towns view is taken to check fracture of condylar neck. High neck fractures of condyle, you can check it with a reverse Towns view. All right, you can easily see the necks of the condyle. The fracture can be easily appreciated in this view. All right. Okay. Yeah. If you can participate, please participate, and please tell me what image. This is image based question. Image based question, and what condition is given in the image. Can you just tell me what condition is given in the image? Come on, what condition is given in the image? Most frequently asked question. This condition is which condition? Geographic tongue. Geographic tongue is also called as wandering rash. Wandering rash. It is also called as benign migratory glossitis, right? It is also called as Erythema migrans. Erythema migrans. Correct. Everybody correct. Erythema migrans. Okay, so these are synonyms of geographic tongue, and this is most frequently asked image based question. And they can give you put one condition that one patient came with the history of psoriasis, and he showed this. The appearance of tongue is like this. Okay, this is nothing but geographic tongue. So association with psoriasis is also discussed in geographic tongue. Association with psoriasis. Okay, so this is one condition that you need to know. Next is many questions were based on candidiasis. Okay, so candidiasis, you must know the classification given by Greenberg and Glick in 2003. Okay, so starting with pseudomembranous and atrophic type. Okay, pseudomembranous, I'll show you the pictures also. Atrophic type may we have denture sore mouth, we have angular cheilitis, which affects the commissures, then median rhomboid glossitis, right? Hypertrophic type may we have candidal leukoplakia, which is also called as hyperplastic candidiasis. Okay, papillary hyperplasia of palate. This were one PYQ in 2024 INI or NEET, right? Papillary hyperplasia of palate. Median rhomboid glossitis, again, nodular type is under hypertrophic type. Then we have multifocal candidiasis, means multiple, you can say, regions are affected. Systemic involvement of candida albicans or candidiasis. Okay, this is syndrome associated in this is familiar endocrine neoplasia syndrome, right? And next is myositis. Myositis associated with thymoma. So these are candidiasis types, okay, that you need to know. First, image based question from candidiasis. First, image based question. What is this? What is this type of candidiasis? Can anybody tell me what is this type? This is pseudomembranous. Pseudomembranous type. Pseudomembranous means you can see curd like lesion. Curd like, typical curd like white lesions. Okay, and you can scrape it off. So this is basically scrapable lesion. You can scrape it off this skull, curd like lesion, and leave the bleeding surfaces, right? So this is pseudomembranous candidiasis, right? Next is this erythematous candidiasis, which is also called as antibiotic sore mouth. Antibiotic sore mouth. Now, antibiotic sore mouth is nothing but when a patient is on the long term administration of antibiotics. Okay, when he is consuming antibiotics for a longer time, then this erythematous candidiasis or this antibiotic sore mouth is seen. All right, so this is also a type of candidiasis. So they can give you clinical based question and put up this patient is on long term administration of antibiotics. Okay, all right. Next condition that we have is this. This is nothing but a denture sore mouth. Denture sore mouth. Okay, this is seen in association with dentures, right? So the surface below dentures have this growth of candida albicans because of poor hygiene. Okay, patient is not cleaning the denture properly, he wears it for 24/7 and he is not cleaning the denture properly, then this condition might happen. Okay, denture sore mouth. Then we have this is nothing but angular cheilitis. Angular cheilitis. Okay, angular cheilitis is also classified under candidiasis. So there can be two causes, either candidiasis or it is also seen in iron deficiency anemia. Iron deficiency anemia. Okay, now in iron deficiency anemia, when you see this condition, how to differentiate between the whether the cause is candidiasis or iron deficiency, you can check for other features seen in iron deficiency. The pallor, you have to check the pallor in eyes, okay, on palms. So you can check pallor and first rule out iron deficiency anemia, and then you can give the diagnosis as candidiasis. All right, next we have this. This is AIDS based question. Okay, AIDS based or HIV based questions, most frequently asked question, are most commonly associated lesion with HIV, second most common associated lesion with HIV, second most common, uh, exceptional exception. So they can give you the options, okay, and the lesions associated with HIV. There will be one option which is not associated with HIV. So they can ask like that. So the most commonly associated lesion is candidiasis. Okay, candidiasis most commonly associated. Then we have second most common associated lesion is hairy leukoplakia. Okay, hairy leukoplakia. Then the Kaposi sarcoma, then non-Hodgkin's lymphoma, then periodontal disease. This periodontal disease includes linear gingival erythema, necrotizing ulcerative gingivitis, ANUC, and ANUP. Necrotizing ulcerative periodontitis. Okay, so these are lesions associated, strongly associated with HIV that you need to know. All right. Okay. Next is now I want you guys to participate. I am going to discuss radiographic appearances seen in which all conditions. Okay, so these are very important. Okay, and they can directly give you ground glass appearance seen in which conditions, cotton wool appearance seen in which conditions. So you need to know all of these, right? So starting with the ground glass appearance. Ground glass appearance is seen in which all conditions? Can you guys participate and tell me? Ground glass appearance. Ground glass appearance is seen in which all conditions? Ground glass appearance, guys. Which all conditions? Yes. Very common. Fibrous dysplasia. Correct. Second most condition in which you see ground glass appearance is hyperparathyroidism. Hyperparathyroidism, right? Ground glass in fibrous dysplasia and hyperparathyroidism. Next we have is the orange peel appearance. Orange peel appearance again seen in fibrous dysplasia, right? Fibrous dysplasia. Okay. Orange peel appearance, ground glass appearance, common in fibrous dysplasia, right? Next we have is the cotton wool appearance. Okay, cotton wool appearance. Cotton wool appearance is seen in which all condition? First and most famous, Paget's disease, right? Paget's disease, FCOD, which is for florid cemento osseous dysplasia. Okay, florid cemento osseous dysplasia, FCOD, is also shows cotton wool appearance, right? Next we have fibrous dysplasia mein bhi sometimes cotton wool appearance is seen. You can write down. And next is Gardner's syndrome. Gardner syndrome mein bhi you can see this cotton wool appearance, right? Correct. Next is salt and pepper. Salt and pepper, we have already seen. Hyperparathyroidism, right? Hyperparathyroidism. May you see salt and pepper appearance. Okay. Next we have honeycomb appearance. Honeycomb appearance most commonly seen in ameloblastoma, right? And the next we have honeycomb appearance seen in central hemangioma. Central hemangioma. All right. Ameloblastoma and central hemangioma. Next we have soap bubble appearance. Soap bubble appearance is seen in which all condition? We have ameloblastoma. Okay. Ameloblastoma. Next we have is a ABC. ABC is aneurysmal bone cyst. Okay, aneurysmal bone cyst. And next is again central hemangioma may be sometimes soap bubble appearance is seen. All right. Then we have spoke wheel or cartwheel appearance. Okay, spoke wheel or cartwheel appearance is seen in again central hemangioma. Central hemangioma. It is also seen in cementoblastoma. It is also seen in cementoblastoma. Okay, spoke wheel or cartwheel appearance. Okay, so spoke wheel or cartwheel like this, right? Next we have tennis racket. Tennis racket appearance. Tennis racket appearance. So there will be perpendicular striae. Okay, tennis racket pattern appearance is seen in odontogenic myxoma. Odontogenic myxoma, right? Next, we have a driven snow appearance. Driven snow appearance is seen in CEOT, calcifying epithelial odontogenic cyst, okay, which is associated with impacted tooth. CEOT, driven snow appearance, right? Next, we have heart shaped radiolucency. Okay, heart-shaped radiolucency seen on the in condition of incisive canal cyst. Incisive canal cyst, okay, or nasopalatine cyst, right? Nasopalatine cyst. Okay, heart-shaped radiolucency just behind the central incisors in the midline. All right. So next is pear-shaped radiolucency. Pear-shaped radiolucency is seen in which condition? Globulomaxillary. Globulomaxillary cyst. Right? Globulomaxillary cyst. Alright? Next, hair on end appearance. Hair on end appearance is was asked in PYQ 2024, okay, 2023 also. Okay, hair on end appearance most commonly seen in thalassemia, thalassemia and sickle cell anemia. Sickle cell anemia. Okay, thalassemia and sickle cell anemia, right? But when they ask you some confusing question with confusing options, you must know there are conditions in which rarely hair on end appearance can be seen. Okay, so first is hereditary spherocytosis. Hereditary spherocytosis may you can see hair on it. You can remember this mnemonic high nest. Okay, high nest. H, hereditary spherocytosis. I stands for iron deficiency anemia. Iron deficiency anemia. All right. N stands for neuroblastoma, which is a tumor of neural origin. You just need to remember the name. No need to go much detail of how it occurs, what is neuroblast. Just hair on end appearance seen in this condition also. Okay. E stands for enzyme deficiency. Enzyme deficiency includes G6PD deficiency. Okay, G6PD deficiency. S means sickle cell, sickle cell anemia. T means thalassemia. All right, T means thalassemia. So you can just remember hair on and appearance seen in all of these conditions also. Okay, most commonly thalassemia and sickle cell anemia, but some are confusing questions. You can remember this. Okay, next is floating teeth appearance. Floating teeth appearance is seen first in chronic periodontitis. Chronic periodontitis, right? Second one in malignancy, squamous cell carcinoma, floating teeth appearance is seen, right? Histiocytosis X. Histiocytosis X. Okay, is maybe you can see floating teeth appearance. Then we have osteomyelitis. Osteomyelitis, maybe you can see floating teeth appearance. Okay. Next is cherubism. Cherubism may you see floating teeth appearance. All right. So please note down these conditions in which you see floating teeth appearance. All right. Why this floating teeth appearance is seen? Because the bone is lost. Okay. The apical bone is completely resorbed. Okay, and destructed, and therefore you see whether uh, even like the teeth are floating in air. Okay, like that appearance is seen in all of these conditions. All right. Next is moth-eaten appearance. Moth-eaten appearance, we all know this is seen in squamous cell carcinoma. Okay. It is also seen in osteomyelitis. Osteomyelitis. Moth-eaten appearance. Alright. Next is onion peel appearance. Onion peel appearance, we already know. We have seen this Gary's osteomyelitis. Gary's osteomyelitis. Gary's osteomyelitis mostly occurs in children. Okay. And it is also called as proliferative periostitis. Proliferative periostitis. So, onion peel appearance. Okay. It is also seen in Ewing's sarcoma. Ewing's sarcoma. It is also seen in osteosarcoma. Okay. So there were doubts raised by the students that onion peel appearance, they ask onion peel appearance is seen in, and they give both in the options. Okay. Ewing's sarcoma and osteosarcoma. Then what to choose? First and basic thing is onion peel appearance most commonly seen in Ewing's sarcoma. So you choose Ewing's in that case. Okay. If they give both of, you can say they give option D as both. Okay. You can mark both as the correct answer, right? Next we have is the punched out lesions. Punched out lesions, we all know it is seen in multiple myeloma. Multiple myeloma, right? Sharpened pencil appearance of condyle. Sharpened pencil is seen in rheumatoid arthritis. Rheumatoid arthritis, right? Next, we have is the pressure type. Now, this is new pressure type appearance. Pressure type appearance means, uh, first of all, it is seen in carcinoma of gingiva. Carcinoma of gingiva, what happens is there is a increased growth, okay, overgrowth of gingiva. So what happens is due to pressure of that growing mass, there is a erosion of underlying bone that takes place, and in the radiograph you see the scoop like area, okay, scoop like radiolucent area, that is called as pressure type appearance. Okay, and this is seen in carcinoma of gingiva, scoop type radiolucency. Okay, radiolucency. This scoop type, I have just used the word for understanding. Okay, radiographically it is called as pressure type appearance. All right. Next we have Codman's triangle. Codman's triangle is seen in osteosarcoma. Osteosarcoma, right? Osteosarcoma. Again, sunburst, sun ray pattern, osteosarcoma. Okay, and Ewing sarcoma may be you can see sunburst or sun ray pattern. Okay, now same question arises when they give a sunburst appearance and they give two options, osteosarcoma and Ewing sarcoma. There you have to mark osteosarcoma. Okay, osteosarcoma as a first preference. If they give both in as a option D, you can mark both. All right. So these are some important appearance that you need to know and you need to understand. All right. And as I have talked about the important topics, please go through all the syndromes, okay, genes associated with syndromes, all the features associated with syndromes, right? Some developmental anomalies. So, talking about dentinogenesis, dentinogenesis imperfecta. Okay, the genes associated with it, shell teeth. Okay, shell teeth, tulip shaped crown, tulip shaped crown, right? All of these seen in dentinogenesis imperfecta. Then we have dentine dysplasia. Dentine dysplasia type 1 and 2. So type 1 is radicular type, okay, which is also called as rootless teeth. And the second one is the coronal type. Coronal type में the pulp chamber of the crown becomes thistle tube shape. So these terminologies or terms are very important when we prepare for INI-CET, because they pick up these particular terms only and they ask you questions. All right, so yeah, this completes our this I will conclude this session. Okay, important topics. Please go through this important topics, and all the best to you guys. And if any doubts are there, you can ask on our Telegram group. Okay, I'll be very happy to answer. Okay, so I think if you have any doubts, we have 4 minutes. We can just clear those out. You can ask. If you have any doubts, you can ask. Fatafat. We can just. Everything clear? All right. Okay. So let's conclude the session. Good night, everyone, and bye.